Dear friends, good morning. This is a festive moment. You know, there are these moments in our life as a researcher and clinician that matter and that we will remember. And so those of you who got up in time and are here in the audience will remember this moment, and those rewatching it online, you missed something. But anyway, so this is now the moment where online, on the Diabetologia website and on the Diabetes Care website, we have the full publication of the consensus on monitoring guidance in early stage T1D. And it has been the work of many, many people. They will be applauded and highlighted during this presentation. And we have key people who contributed and led this initiative as speakers, and they will introduce everything, every detail to you. Also, the slides, I guess, will be available at one time for you to use in your presentations. I will stop my introduction. Please, if there are questions, we do hope to have time at the end for a vivid and active discussion. You cannot suggest changes, it's published. So it will be for the next, version. But I now want to give the word to the person who really put everything together and was the motor, really, the electric, the hybrid, the diesel, the everything motor behind this initiative, and that is Anastasia. You know, in Europe, we're not politically correct, so this is my friend Anastasia, but I will also say Miss Albanese O'Neill, who has really driven this initiative, and she will introduce it all. Thank you.
Thanks for getting here this morning on the buses and Monday morning traffic in Orlando. We're delighted you're here. It's great to see a lot of friends in the audience. I just want to take a couple of minutes of your time to talk about the genesis of this project. When I started at Breakthrough T1D, formerly JDRF, 2.5 years ago, I was asked to do an analysis of the barriers to participation in screening. We've had about 250,000 Americans participate in screening over the past 20 years in TrialNet, and several 100,000 around the globe. And what immediately came clear was a fairly profound clinical gap. And that was that aside from the ISPAD staging guideline from 2022, there was no international consensus on how to care for children and adults in early stages of type 1 diabetes who were autoantibody positive but had not yet progressed to stage 3 or insulin dependence. And as clinicians, and there are many in the room, when we order a lab, we want to know what to do with the result. We want to have a clear plan of care about what to do next. And we did not have that for type 1 diabetes screening. So 19 months ago, we convened an effort with experts in the field, and it was clear, and let me advance my slides. It was clear, as you can see on the slides, that we had a really robust response. 73 experts from 11 countries on 4 continents agreed to participate in the effort, and I can confirm, as Chantal noted, that this is now officially online as of 8 a.m. this morning for the field. And I think this is answering now a very important clinical question. But I also want to say, as the parent of a child who participated in a screening study for 15 years, the TEDdy study, I believe this is also a day of celebration for families and individuals who have stepped forward around the globe and participated in screening. And in particular, people who are living with some degree of uncertainty with positive autoantibodies and have not yet progressed to stage 3 type 1 diabetes. We know now that when they meet with their care team, they will not only have a medical plan of care, but also their educational needs and psychosocial or psychological care will be addressed. Finally, I want to acknowledge all of the authors that aren't here on the dais, but contributed to this work. It represents over 1,000 years of type 1 diabetes expertise, over 1,000 years of type 1 diabetes expertise, and this was an unfunded project. So they dedicated their time unselfishly and frankly generosity of spirits when things got hot in terms of debates to get this to consensus and get the guideline in print. Without further ado, what we're going to do today is I'm not going to come back and see you and introduce everybody. I'm going to introduce Professor Moshe Philip from Schneider Children's, who is going to talk about why this consensus was necessary in more detail. Professor Linda DeMeglio from Indiana University, who will share with us how it came together in terms of the methods. Dr. Kurt Griffin from Sanford Research, who will share with us the guidance for pediatrics, children and adolescents. Dr. Rivka Schulman-Rosenbaum from Northwell Health, who will talk about guidance for adults. Brigitte Fraunert from the Barbara Davis Center for Diabetes at the University of Colorado, who will talk about education and psychological guidance. And finally, Dr. Sanjay Dutta from my organization, who will talk about the gaps where we couldn't reach consensus and where we need more evidence. And he's a great person to do this because he'll probably have to pay for some of it. Without further ado, I would like to introduce Dr. Moshe Philip.
Okay, so I'll try to describe to you the rationale behind the need for such a guidance. These are my disclosures. And the question that assigned to me today, this morning, to talk about is, why do we need a guidance document? So I refresh your memory that on November 17, 2022, the FDA approved and released that they have approved teplizumab, the anti-CD3 injections to delay the onset of stage 3 diabetes in adult and pediatric patients 8 years and above that have currently stage 2 type 1 diabetes. They specifically said stage 2. And not only that, the ICD now have codes for new situation. Type 1 diabetes, pre-symptomatic, if you look at the ICD different codes, you can see that there is a code for stage 1 and stage 2. And when I talked with people about it, I got a query faces. What do you mean stage 2? So just before I continue, I wonder how many in this audience have learned in their medical school about stage 1, stage 2, type 1 diabetes. Not all of you together, please. None. So it's new. It's new for many endocrinologists. It's new for diabetologists, but it's especially new for PCPs and pediatricians in the community and other healthcare providers. So let's refresh our memory about what is stage 2. Stage 1 are people who have normal glycemia but have 2 positive antibodies against insulin, or typical for type 1 diabetes. Stage 2 are people who have 2 positive antibodies, but also some dysglycemia. And stage 3 is the diabetes that we know, the clinical stage 3 that answered all the criteria published by the ADA in the past. So just to stress the point, stage 1 and stage 2 are already with type 1 diabetes, whereas those with 1 antibody or those with genetic background are considered to be at risk to develop diabetes. So stage 1 and stage 2 together sometimes are called early stage, pre-stage 3, or pre-symptomatic type 1 diabetes. Does it change? Okay. So why are we talking so much about stage 2? Because stage 2 have 100%, almost 100% chance to become one day stage 3. And this is a group that we are extremely interested in identifying and in following, and not only stage 2, of course, stage 1, because some of stage 1 will turn to become stage 2, and then stage 2, almost all of them will become stage 3. So what is the purpose of the monitoring of those people with stage 1 and stage 2? The primary purpose is to prevent the presentation with ketoacidosis and diagnosis. It also allows us time to plan and prepare for the day that stage 3 will come. It will allow us to refer people with type 1, stage 1 and stage 2 to the right places to be followed up. And identification or finding people with stage 2 will allow us to enroll them into intervention studies or to proper therapy that is available or will be available in the future. Who is the audience for these consensus guidelines? So the audience are PCPs. We are convinced that with the progress of screening programs, and because people are more aware now of the fact that there are opportunities to screen, there will be more and more people with positive antibodies that will go to their physician and ask them, hey, what should I do? I have a positive 1 antibody, 2 antibodies. So the primary care providers, whether they are pediatricians or general practitioners, are the audience, and also our friends, the endocrinologists and diabetologists, the nurses and other healthcare providers. We should not forget people who are responsible for educating or the education of the people with diabetes, and also those that provide psychological support. And we should never forget that it's also important for individuals with the risk to developing type 1 diabetes and their families. This slide is taken from a publication by Rachel Besser in a manuscript about different screening programs that are out there. As Anastasia already mentioned, ISPAD were the first to go out with some kind of guidance of how to define this different staging, and also they specifically focused on children and adolescents, whereas we increased the scope of the guidance. They describe a lot of studies that have been done in family members, a lot of studies that have been done in general population. Our consensus document is not touching the issue of whether screening is a good idea or a bad idea. We start with a person who has a positive antibody, regardless of how did he get to have it. Just want to mention that in September 13, 2023, the Italian Parliament voted in favor of having a national screening for type 1 diabetes, and as you can see, no objection were there. So where are people with positive antibodies, where will they come from? Some of them will come because they know that they have genetic risk and went to measure the antibodies. Some because somebody in the family has diabetes and they decided to measure their own antibodies, or their physician referred them to do so. There are in different places, like in Italy, but in other countries, Germany and other places, general population screening programs that will detect those with positive antibodies, and some will just ask their physician to send them to be screened. So In our document, we would like to focus, and actually we focused on what is the purpose of the monitoring, how and when should we monitor these individuals, what do we do with a single antibody positivity, and who should monitor, what defines stage 2, when should we begin treatment, and we did not forget and focused a lot about education and psychosocial support. And with that, I would like to invite Professor Linda Domingo to continue the presentation.
Thank you, Dr. Phillip, and thanks to everybody who worked on this guidance. I'll acknowledge everybody at the end. So these are my disclosures. And I'm going to talk about in the next 10 minutes is how the guidance was developed, and then I'm going to start us off with a very high-level overview of the document. So I'll just start with where this began for me personally. So there was this initiative, and you can see the title of it in the top left. And in September 2022, I got a phone call of an email that was requesting a phone call, then a phone call from Dr. Albanese O'Neill. And she described what she wanted to do, and I said, well, that sounds really interesting. Can you send me an email summarizing what you're asking me to do? For those who came to my Saying No talk the other day, that was my 24-hour wait until I said yes. But I also, but she gave this brief summary, and I show it here in part just to say that we really did what we said we were going to do, which was remarkable, because I think I said during the phone call, I said, that sounds pretty ambitious to try to get something really drafted on this huge guidance at this point in about 7 months. And so obviously I agreed. And then a group of us, some of the people up here, put together a set of author invitations, and we invited people. We also internally drafted a mission statement, which I'll show you, and then pulled some preliminary references so that we knew where we were in this space. We then began a series of planning Zoom calls and identified Rob Rines as our medical writer, which was a huge benefit. Fortunately, Dr. Phillip had worked with him before. And the mission that we developed at that time was to develop a consensus document based on expert opinion and current evidence to specify the necessary monitoring guidance and a basic management approach for people with antibody-positive pre-stage 3 diabetes to follow them for progression and use it in clinical practice. And the idea was to include, which we have in the document, what endpoints to monitor, how frequently to monitor, and then immediately how to provide psychological and educational support along the way. We also talked about age and other biomarker and contingency-based, and context-based contingencies and adaptations. I have these in italics at the bottom because these were added a little later. They weren't part of the initial mission, but we realized we needed them. And then we also, in the guidance, have a section about what additional evidence is needed in this space. For example, biomarkers, risk factors, assessments, efficacy of approaches. And when you look at the guidance, you'll be struck by how many of the levels of evidence are E, so just expert opinion, basically, and how much additional work there is to do. That's part of why we realized it had to be guidance rather than guidelines, just because there was not enough evidence in many areas. We then had our first, as scheduled in that initial email, our proposed meeting at ATTD in February of 2023. And this is the agenda that we distributed from the meeting, and you can see at the bottom the group of people that were there. We started with just an overall introduction, and then what we did during that meeting was a lot of review of what was already done. We talked about the state of science and monitoring, the monitoring guidelines. We had representatives of various screening programs come and just talk briefly about their programs and where they were. And then we spent the bulk of our time on what we needed to do next with a moderated discussion. At that time, we confirmed what we thought walking into the meeting, which is that we were going to set up working groups. And we asked people after the meeting to sign up for various working groups and then distributed the people across that. We also, of course, had lunch so we could get to know each other. So these were the subgroups that were formed based upon self-nominations and some selection after that meeting. So monitoring in children and adolescents with Rachel Besser and Kurt Griffin. Kurt will be speaking a little bit. And then subgroup leads, I'd like to acknowledge everybody that led a subgroup because the pediatric group had a series of subgroups. Monitoring in adults, and Rivka and John Wentworth led this. Educational needs led by Kristen Bell and Briggs Fronek. and the psychosocial interventions led by Kim Driscoll and Laura Smith. We then had working group meetings. Since we were spanning all those continents and countries, we did them over Zoom, and we had over 21 meetings, which either, I think Anastasia attended every one of those. The medical writer also attended every one. Moshe and I divided them up, and we listened, and we had recordings, and we reviewed evidence, and we graded recommendations. And indeed, a year ago, we met in San Diego, and we had a draft of the document. It was draft version 6.6 for those who are following along. And we had made great progress. Over the next couple months, we did further drafting and reviews. There are several things that came up during that session that we just needed to address and figure things out. We submitted an abstract, first to ISPAD, and then we had a presentation at ISPAD, and then ATTD. And we did these public presentations. So here's Dr. Philip presenting from Tel Aviv in October of 2023, and then me at ISPAD, and then me presenting at ATTD in March of 2024. By March of 2024, we were really ready to have all the authors kind of take a deep read of the document. We thank everybody who read through it and we got extensive comments from many people. We got additional revisions. And then eventually we submitted it in March 2024 for ADA review. There were a series of revisions, re-reviews, rechecking of things, and eventually, as you know, the manuscript was accepted. We ended up at the draft version 28 of what was submitted. I'll say there were a couple other versions for version control until we actually got it all ready into proofs. And so here we are at the end of what was a 19-month gestation period here at ADA 2024 at the finish line. This, as was mentioned, it's published in Diabetologia and Diabetes Care. Now, how long is 19 months, you might ask? Well, it's long enough for a sperm whale, which is apparently, I've learned, the longest gestating mammal on the planet, like the longest to gestate it. And it's long enough that your sponsoring organization changes their name. So it's a long time. So our path to these guidelines was not like this really smooth road to this horizon, although we got to our goal. It was more this kind of winding path, but I think it made for a much richer product. And I'm very privileged and proud to have been part of this process. But as I told you up front, there's going to be a little bit more to my talk. So I've talked about how the guidance was developed. I'm going to now start you off on a high-level overview, and it's going to then continue through the next speakers. So you cannot see this from the back of the room. You can look at it online now. But this is the suggested model, and I just show it to you overall, not expecting you to read it, but just so you know that the guidance starts at the very top with somebody with a positive antibody screen, and then goes to the bottom to somebody who's got stage 3 diabetes. I'm going to take you through that arrow on the left, which talks about where people are supposed to, like where the care is going to happen. Oh, sorry, I didn't move forward. Thank you. I'm seeing it here in front of me. You're not seeing it. This is the high-level overview. At the top, positive antibody screens. Bottom, to the diagnosis of stage 3 diabetes. And on the left-hand side is the continuum from primary care at the top to the pediatric or adult endocrinologist. I'll give credit to Dr. Griffin, who conceptualized this document, and then all the people who did iterations. I think it helps a lot as like a roadmap of what to do. So that arrow on the right, I've now taken and drawn it out here for you. And we're going to use this color scheme through the next talks, where primary care is in blue and the transition to pediatric and adult endocrinology is going to go to red. The idea is that over time, as more and more people get screened, that primary care and general practitioners, and there were primary care folks in the room, and they're on the masthead of this. We had them engaged in this process. And for that person, somebody who's single antibody screened, whose initial antibody screening should be done in that setting, single antibody positive individuals may be monitored in that setting, and then multiple antibody positive, particularly at stage 2, is when the transition should happen to pediatric and adult endocrine care. So just to go through the guidance around that collaboration with primary care, again, all with expert level opinion, but primary care providers should understand the stages of diabetes, methods of and suggested frequency for metabolic monitoring. The primary care provider, specialist provider, and the person who's antibody positive should determine who will have primary responsibility and what degree of collaboration is needed. And this will shift over time as somebody progresses through to stage 3 diabetes. Medical records must reflect the antibody status and the plan for monitoring urgent evaluation if needed. And then I'm just going to close my section by just acknowledging all the various organizations who have signed on to this document, provided feedback on this document, the representation from NIDDK, the Exchange, the Helmsley Charitable Trust, Here I list all the authors, and I highlighted here the group leads, but I also want to note here a couple people in blue that advised the process, but are not listed on the masthead. So we have a few people that did that played that role that were also really critical, but because of their professional roles, we're not able to be listed at the top, but were very helpful. And with that, I will turn things over to Dr. Griffin to talk about monitoring in children.
Good morning. And I would like to just start by saying I have no disclosures that are relevant financially. I do have to disclose that my name is up here, I'm presenting, but this is on behalf of a lot of people. Again, Linda DeMeglo just listed everybody involved. The pediatric subgroup had probably the largest and a lot of interest, and we tried to break it up into 4 subgroups, so I really benefited from the help. Rita Viola, Jenny Cooper, Maria Craig, and Kimber Simmons for taking each one of those and bringing them back and helping us to put it into something a little more coherent. So if we look at the beginning of this process, as we start screening, and we intentionally did not go into the question of who should be screened, when should people be screened. That's a much bigger discussion for another day. But we're just starting with, we have somebody who's screened. One of the key things that has been coming up in more and more discussions is the notion that there are a lot of people who may have a transient low-level antibody, and that by itself is not necessarily something to be too worried about. It's more when that antibody is persistent, you measure it again. We can argue about whether same, different methods, etc. But having that persistent antibody, that's a different state than just having that first sample. So it's really critical to confirm that initial antibody with the second test. As we think about how this is going to work, hopefully someday in real life when this is released into the wild, we're trying to think about how can we implement this. And again, Linda talked a little bit about how we had primary care involved in even these discussions. But in my mind, we're really trying to model it after how do we do other screenings. And as a pediatrician, we were used to thinking about lead levels, we're used to thinking about hemoglobin, things that we do fairly early in life. Now we do, starting at age 9, we're supposed to be doing lipid screening. So all these things that are supposed to enable us to intervene before somebody gets into real problems. Newborn screening, that's probably the best example. And as we look at this, the reality is if we're screening a lot of people, this is necessarily going to have to be in primary care. There aren't enough specialists, full stop. There's not enough bandwidth for this. And I think that includes even how do you do that initial, when you get that initial positive screen, how do you have that reflex to, all right, let's get a second sample, let's confirm this, be sure that this is actually something we need to worry about it. And then once we have the persistent antibody, that's where we can start doing. If you just have a transient one, the second one's negative, I think it doesn't hurt to provide some education about, hey, just in case something changes, here's what to watch for symptom-wise, how to intervene. But probably don't need to do much more in the way of follow-up because they had that initial transient little antibody. Once they have persistent antibodies, we know that a lot of people that we screen, especially as we start really young, they have just that single positive antibody. If that's where they are, we want to keep an eye on that. And especially one thing that has really come up and baked into these documents is the risk varies depending on how old the child is. In particular, a young child with a first antibody, they are at higher risk of getting the second antibody quickly. If you make it to a teenager and you just have that one smoldering antibody, probably less likely to progress that quickly. So the frequency at which we retest is going to be very depending on how old somebody is. If they just kind of persist at one antibody for a long time and they don't progress, that's where probably we can back off. If they do progress, then that's where we say, okay, second antibody, now you have type 1 diabetes. We can argue about what stage. So what did we come up with for the single positive antibodies? First and foremost, and this is, as much as we really put a lot of emphasis into monitoring and thinking about how we can intervene, probably the biggest intervention is being sure people are aware of what are the symptoms, how do they recognize who to call when something changes so that we can avoid DKA. And I'm saying this as somebody who's still seeing patients, And in our system, across our footprint, it's 70% of the kids who come in with new onset type 1 are already in DKA. And we know that that has long-term impacts. In terms of monitoring, first thing is for the younger kids, again, we want to check on them a little more frequently. What we settled on is, we'll use the term consensus perhaps a little loosely, but this is where we got to. If they're under 3 years, checking them every 6 months for 3 years, and then annually for 3 years. And if they've really not progressed beyond that single antibody, that's where we think we can probably let go. And again, a little education of, keep an eye out for these symptoms is probably okay. If we find them when they are already over 3 years, probably we can just go to the annually. They're less likely to progress quite so quickly. And then again, if it's no progression after that kind of 3 year period, they get to be 6+, maybe we can back off a little bit. I did neglect one other disclosure, and that is we talk about this as a linear process, and Dr. DeMaglo had that lovely slide, 2 lovely slides that showed a unidirectional arrow. We know that some of these kids will bounce back and forth. Some of these kids will go from stage 1 to stage 2. Occasionally we'll see stage 1 to stage 3 while we're not looking. So always being aware, having the families be aware is really important. All right, and then here when we talk about keeping an eye on metabolic monitoring, this is, again, if they're stage 1, not even stage 1, this is single antibody. Probably not a bad idea to just keep an eye on at least a random glucose or a hemoglobin A1C just to kind of catch things. And we'll talk a little bit more about some monitoring. And again, if they're not really progressing over antibody-wise or glycemic-wise after a couple of years, then we can probably back off. All right, if we look at the next stage of I shouldn't use the term stage, but the next part of this, as once we get to where we have 2 more positive antibodies, that's where we're saying you have pre-symptomatic type 1 diabetes. And this is where we kind of up the game a little bit for the metabolic monitoring and first figure out where is somebody in terms of their staging. Are they still normal blood sugar in the stage 1? Is it impaired stage 2? And I'm actually happy at the last Peds Endo meeting last month. It was nice to hear a lot of the pediatric endocrinologists starting to use these terms and know what they mean and starting to ask questions about them. So it's taken almost 10 years, but I think we're at least in the Peds Endo community getting some traction with this and getting people familiar with it. Of course, stage 3 is where we would like to someday prevent people from getting to, but if that's where they are, that's, again, something that we'll set aside for a different day. Along all these, we have the opportunity to see what trials are available, what interventions may be available, and along the way, still always providing that psychosocial support, providing that education. We think that's probably most important right as something changes with that first antibody, with that second antibody, the blood sugar changes. There's an immediate need for, okay, how is this different from where I was? And we'll hear a little bit more about that later. So here for monitoring, again, one of the things as part of this consensus is the realization that not every place is Orlando, Florida. Not every place has access to the same resources. So what are some of the different ways different people could do things tailored to their local resources? The classic is the OGTT. This is a gold standard. This is what ADA had diagnostic criteria set for decades. Involves multiple blood draws. It's useful for the staging. It's useful for opening doors into trials, potentially opening doors for intervention. Not necessarily a trivial thing, especially if you have a little kid, but it's kind of what we're used to working with. I know when screening adults for type 2, hemoglobin A1C has become a lot more common. It's a little easier, not as expensive as it used to be. One of the key differences here is this is a lagging indicator. So as a 3-month average blood sugar, you can have somebody, particularly if they're transitioning quickly, they can cross into significant hyperglycemia, even DKA, before you have time to accumulate that physiologic integrator signal of glycemia. One of the things that we're seeing being discussed a little bit more as far as how to use this is not the absolute number, but rather looking for a longitudinal change. And particularly if you increase 10% over baseline, so say going from 4.5 up to 4.9, nice normal A1C, but that's an indicator that things are progressing even before you get to where you're in trouble. Where we do have more modern technology, and in some countries this is actually either even ahead of where we are here in the US, continuous glucose monitors. And this is new. We're trying to figure out how does this correlate with the gold standard of OGTT. Some families, some children put up with this a little bit better than trying to come in and sit around for 2 hours and have multiple pokes. Gives us a lot of other information. Andrea Steck, I know, is in the audience. She's been looking at some of these data from studies already and proposing time over 140, greater than 10% as a marker that a progression is coming that might actually indicate that you're already at stage 2. This is still early. We're continuing to get information. We're gathering information from across a number of different studies, trying to harmonize all that. It does not come without a little bit more of a cost too. You know, each one of those devices, they're getting less expensive, but they do have a cost. Simple self-monitoring blood glucose, finger sticks. Lower cost, you do have a little poke. I think this is what we were all used to for a lot of years, just in managing type 1, so we know kids get used to it, families get used to it, but it does have a little bit there. Just a random serum glucose. This can be helpful, particularly if it's a postprandial, relatively low cost, and can still give us some information. And then some people, again, more in the adult world, rely on C-peptide to really distinguish between type 1 and type 2. Is somebody still able to make some blood sugar? I think particularly in children, particularly as you progress towards type 1 diabetes clinically, this is not necessarily a great measure just in terms of if you have somebody that's not actually having that high of a blood sugar, the C-peptide can be low and it can be appropriate. And I see this in my screening program all the time. Flip side, if you have someone come in DKA, they can actually have low C-peptide, even in that state when they're very high blood sugar, and then come back and as they get under better control, start making more insulin. And I would like to credit Dr. Bertha Schumann Rosenbaum for coming up with this slide and developing this, and we've adjusted a little bit. All right, so if we look at the kids who have stage 1 of type 1, so these are multiple antibodies, normal blood sugar. Again, we come back to the notion of education on what we're going to do, what to watch for, what are the symptoms of DKA, having simple written instructions that we can give them, they can rely on. And I know for our program, we have something that just can go right on the refrigerator and hopefully help people follow through with that. If they are sick, we ask them to check blood sugars. If they have a recent conversion to positive antibodies, we ask them to check a little bit more often. And then if they're not having problems, we can space that out. And again, we just talked a little bit about the various ways that we can do this, and that'll vary according to where we are and what the program is. The frequency, again, I said the younger kids are at higher risk of progressing more quickly. So the younger kids, we're talking about at least an A1C every 3 months. We can talk about how to measure glucoses as one-offs in between, or as OGTT. And as we get older, 3 to 9 years is probably every 6 months. And after 9 years, we can probably get away with every 12 months. And again, different places are going to probably implement this differently. Again, the OGTT can open the door to treatment or potentially intervention trials. And this is also, as we get to stage 2, referring to somebody who actually is an expert in the field, getting connected with a clinic that someday is going to be taking care of them. Stage 2, I think what was quoted here is 75% progression in 5 years. It's actually 50%. Median time is about 2 years. So this is a good time to get them plugged in, be sure they have meters. In my program, we actually give ketone strips as well. And then we monitor them a little more closely every 3 months. Stage 3, we are intentionally not talking about today. A lot of you've noticed I didn't go through the grade of evidence for each one of these. As was mentioned earlier, this is a lot of expert opinion. As we get to how and when to start diabetes, I think we push from expert opinion to even not even having that much experience yet. So this is an area where we need to develop more experience, more data, and more evidence eventually, we hope. So stay tuned for that. And again, I'd like to thank everybody who's contributed to this, and I will pass off to Dr. Rivka Schumann Rosenbaum. Thank you.
Good morning, everyone. Now that you've heard about our pediatric guidelines, I'll be walking you through the adult guidelines. And here are my disclosures. So, first question I want to pose is, why do we need separate adult guidelines? Why is it different from pediatric guidelines? And over the next few slides, before I go into the meat of what we're recommending, I just want to explain a little bit about how adults are different from pediatrics when it comes to early stage type 1 diabetes. And some of the concepts we're going to go through in the next few minutes include the fact that the adult side of this is far less studied. There are very high rates of misdiagnosis. The progression is much slower. And then there's the issue of pregnancy. So firstly, adult early stage type 1 diabetes is far less studied. While we have many longitudinal cohort studies and registries that focus on the pediatric population, we do not have very much data on adults, and the little data we have, it's only on younger adults below the age of 45. And so that brings a lot of challenge to coming up with recommendations when a lot of our data comes from pediatric, and how do we relate this for recommendations for adults. Furthermore, while there have been published guidance documents for pediatrics previously, namely ISPAD document 2022, there have never been published guidance on adult early stage type 1 diabetes until very early this morning. Misdiagnosis is a very large problem when it comes to adult early stage type 1 diabetes. And that is because the traditional paradigm is, well, children have type 1, adults have type 2, which is completely false because both diseases can occur in all age groups. And misdiagnosis is particularly dangerous because if someone is given the diagnosis of type 2 diabetes and prescribed metformin or GLP-1 or something else that's not insulin, and they have an insulin deficient state, then they're at risk for DKA. And I do see these patients come into the hospital in DKA because they have been misdiagnosed. This is a real clinical entity, and it's happening. And type 1 can be confused with several different types of diabetes beyond simple type 2 diabetes, ketosis-prone type 2, so they actually can have DKA, MODY, type 3C diabetes, pancreatic cancer. The NHIS survey looked at the age distribution of new onset type 1 diabetes for a nationally representative sample, 2016 to 2022. And they found that the median age was 24 for the new onset of type 1 diabetes. 24 is in the adult age group. Other studies have shown age 35 or other medians that are even higher. And it actually turns out that more individuals are diagnosed in the adult age group than in the pediatric age group. And 37% were diagnosed above age 30. So this is a real significant issue that many providers are not aware of, not to mention patients. Additionally, other staggering number is that 40% of those developing type 1 diabetes after age 30 are initially treated as type 2 diabetes. And part of the challenge is that there is not one single clinical feature that can determine if someone has type 1 diabetes. For example, age, BMI, history of DKA. So it's complicated. Another challenge is the fact that adults progress more slowly. They also may not present with classic full-blown symptoms of type 1 diabetes. They may still have C-peptide at the time of diagnosis. And there is a slower decline in beta cell function over time. Here you can see some data from a TrialNet cohort, relatives of those with type 1 diabetes being monitored for diabetes-free survival over time. And the red lines indicate age greater than or equal to 20, so that's our adult age group. The other colors are all representing various pediatric age groups. And so you can see the diabetes-free survival is much more gradual, the decline. Patients are more slowly progressing to stage 3. They do progress, but not all of them progress. And then we have something challenging called, well, some will call it LADA, some will say it's not called LADA. So LADA, latent autoimmune diabetes in adults, is a somewhat controversial term, but it refers to a clinical entity describing adult patients with a slow autoimmune progression that culminates in type 1 diabetes. So some would just categorize this as adult onset type 1 diabetes. But I think it is important to understand these patients that initially present with what looks like a type 2 phenotype. They have detectable C-peptide. They may be intermediate for adiposity and insulin secretion, but they may be doing just fine on type 2 therapy. So they may just be walking around on type 2 medications with a good A1C doing fine, and then they actually have a positive antibody or antibodies unknowingly, and as time goes on, their C-peptide declines somewhat gradually, but then they get to the point where they're losing weight and their A1C is shooting up, and someone needs to figure out that this person actually has this entity, which, LADA or type 1 diabetes, whatever you want to call it, because you want to identify them before they get to the point of losing all their C-peptide, because they can develop DKA. So this is really quite a challenging thing, and also oftentimes only single antibody with GAD for these patients. They could also lose their antibody positivity after 10 years, just to throw another challenge in there. And then, of course, there's pregnancy, which needed to be addressed in the guidelines with very little data to work with. So I'll be talking about what we put together for guidelines in a moment. So jumping into the adult recommendations. So firstly, single antibody positive adults. So these are individuals we would refer to as at risk for early stage type 1 diabetes, right? Because they only have the single antibody, just to get our terminology straight. So we recommend confirming persistence in a second sample, preferably with a reference lab. If only transiently single antibody positive, so it's negative on the repeat, there's no need to monitor. If someone is single antibody positive and they have additional risk factors such as first degree relative with type 1 diabetes or elevated type 1 diabetes genetic risk score, dysglycemia, or history of stress hyperglycemia, we recommended for these individuals annual metabolic monitoring. And you heard before what the options are for metabolic monitoring. And just to add that when we gave all the options for metabolic monitoring, we made sure to give multiple options, understanding that these tests will be done in all different clinical settings and different scenarios, ranging from PCPs to endocrinologists. So annual monitoring for single antibody with risk factors, but without the extra risk factors, we recommended every 3-year metabolic monitoring for single antibody positive adults. There is a risk for them. It's not a very high risk, so we felt that we did not need to give very aggressive recommendations, but we still wanted them to be monitored in some fashion. And the reason that we picked every 3 years is based on the fact that that is the frequency used for screening for type 2 diabetes in the general population, age over 35, et cetera. So it is doable. Moving on to stage 1 type 1 diabetes for adults. So again, we recommend confirming persistence of the antibodies, second sample, and preferably in a reference lab. We recommend that patients are given a glucose meter so that they can self-monitor blood glucose at home, particularly with illness or symptoms as they arise. And importantly, for stage 1, we recommend hemoglobin A1C every 12 months as part of their primary care visit, which is very doable as most patients would have an annual physical and get annual blood work. This could be modified, the frequency could be modified based on any individual parameters, number of antibodies, glycemic metrics, et cetera. Now, if that hemoglobin A1C changes 10% or more, then that would trigger the recommendation to perform an OGTT for more staging. If the patient is normal glycemic for 5 years, you can decrease the frequency to every 2 years. Stage 2, type 1 diabetes. So now that patients are a little bit higher risk, so we recommend referral to an endocrinologist at this point. And instead of the 12-month intervals for stage 1, we recommended 6 monthly intervals for stage 2. So these are, again, our patients with dysglycemia, 2 antibodies or more, and dysglycemia. So we recommended still doing the A1C at each of the 6 months, but also adding one other modality, just to make sure that we're not missing a recent onset hyperglycemia, just doing the A1C. So the second modality could be a blinded CGM. It could be increasing the frequency of self-monitoring blood glucose by weekly fasting or 2-hour postprandial, or an OGTT. Again, if the hemoglobin A1C increases by 10% or more, this should trigger the OGTT if it has not yet been done. And importantly, we wanted to include a point about the C-peptide, the usefulness of this in the adult population, because sometimes it really is hazy whether the patient has type 1 or type 2 diabetes. And I find it very clinically useful to use the C-peptide. But you do need to always check a serum glucose at the same time to make sure that you are able to interpret the C-peptide result. So if the patient is hypoglycemic, you can get a falsely low C-peptide or severely hyperglycemic or very recent DKA. So in those cases, you wouldn't want to rely on the value. But if you have a euglycemic patient, especially if they're not fasting, with a very low C-peptide level, less than 0.2, combined with a positive antibody status, that would be very reassuring for type 1 diabetes. And now moving on to pregnancy. Pregnancy is an area with antibody positive individuals that we have really very little data to work with. So we did our best to come up with recommendations based on other things that we do know about hyperglycemia and pregnancy. And we do know that pregnancy is a very high-risk time for mother and fetus when it comes to hyperglycemia, which can be associated with fetal anomalies, especially in the first trimester, and other challenges with hyperglycemia in second and third trimester. And we felt that it would be a shame to not diagnose someone with stage 3 in the first trimester if we could. And the thought is that just as if someone who could be normal glycemic and then develops gestational diabetes due to the increased stress during pregnancy and challenge on beta cell function. So we decided to be a little bit conservative in what we recommended, which was that anyone who's antibody positive who becomes pregnant should have something to measure their glucose, ideally by 8 weeks. And we did give options. It could be an OGTT, a hemoglobin A1C, or a CGM. If those are all negative, then they should still undergo standard OGTT at 24 to 28 weeks, as is recommended for all pregnant women. And in the postpartum period, we did recommend an endocrine consult to help differentiate the need for ongoing insulin in patients who did require insulin during pregnancy, antibody positive individuals, and that's because it's possible they had gestational diabetes and it's resolved, but it's also possible that they've now progressed to stage 3 during their pregnancy. And teasing that out really would ideally involve a specialist. They also should be monitored for 6 to 12 months postpartum, as there can be fluctuations in requirements and status. We have a ton of unmet needs when it comes to adults in this area. We need more data and research focusing on the adult population. We need to better understand rates of progression to stage 3 in antibody positive persons without a family history and especially non-European ancestry. We need to understand more about the cost effectiveness of the monitoring strategies that we're recommending. We need to truly understand the implications of single antibody status or LADA in adults. And the ICD-10 codes, as mentioned, are coming soon. They should be available October 1st, so that's really exciting. And I just want to thank everyone who participated in the adult subgroup for this guidance document. This was truly a group effort and really tremendous work by everyone on this slide, so I wanted to thank you all for that. And now I'm going to be introducing our next speaker, Dr. Brigitte Frohnert, to talk about psychosocial and educational considerations.
Thank you. So I'm going to talk today about the work of 2 groups. I don't have any disclosures that are relevant. And to start off, I want to acknowledge the members of the group, and particularly my co-lead, Christine Bell, for the education section, and the co-leads for the psychosocial support section, Dr. Kimberly Driscoll and Dr. Laura Smith. So psychosocial support and education have been mentioned throughout this talk. So let's talk a little bit about why are they so important. One of our main goals with monitoring early stage type 1 is to avoid DKA. Long-term engagement with the team is critical for this outcome. So we know with quite good evidence that people who engage in long-term monitoring do have significantly lower rates of DKA compared to the population. But screening alone doesn't prevent DKA. In fact, if you look at data from several studies, including more recently the FRIDA study and the ASK study, the people who participate in monitoring have the lower rates of DKA. Those who are merely told that they are at risk but decline participation in monitoring have rates that are either same as the background population or intermediate. We also know that if you engage in monitoring, when you do progress to stage 3, you have less severe symptoms at that point. However, there's a challenge. Some children, and indeed most adults, go years before progressing to stage 3 T1D. So keeping people engaged can be quite a challenge. The other part of early monitoring and education is that there is this opportunity of a longer lead time before the onset of stage 3 T1D. So anybody who has treated a family with a person with a new diagnosis of type 1 diabetes, particularly if they're diagnosed with DKA, understands this is a very traumatic event for the family. We have the opportunity with early identification to have a smoother introduction to type 1 diabetes, some time for the family to process the news while the child is still well. There's ability to evaluate for and address both individual and family strengths and stressors that will be so important in terms of impact on later insulin use. And there is also a gradual introduction to type 1 diabetes knowledge and skills. So, one thing I wanted to also point out before I continue is that there is limited evidence on psychosocial support and education, specifically in early stage T1D. There are some aspects for which we have good evidence, including the prevention of DKA, but a lot of our recommendations are coming from extrapolation from what we know in stage 3. So the psychosocial impact of risk information. I think this is one of the biggest concerns of general practitioners who are considering screening is what am I going to do if I give this information to families and that causes them great distress. So we know that when you tell someone about risk by its nature is unpredictable, uncontrollable, and threatening. And so telling someone about risk is a highly stressful event for most. The emotional and behavioral reactions can be varied anywhere from shock, grief, anger, depression, and anxiety. I'm going to briefly discuss some of the evidence of emotional responses across time, but I encourage you to, if you weren't at the session on Saturday on screening, Dr. Suzanne Johnson did a really nice job of describing what's been done in previous studies. So we know that parent anxiety often declines if somebody with a single antibody does not develop additional antibodies. However, if they have multiple antibody positive, they continue to remain anxious. There is some association between lower educational attainment and higher levels of parent anxiety. And then one of the most important factors in terms of families' response is their background experience. So people with a family history of type 1 diabetes often have higher anxiety with the news of early stage type 1. Those without a family history of type 1 diabetes, conversely, might underestimate the importance of follow-up and what this really means. And in addition, although most of the data we have is around parent response, children do also report elevated levels of anxiety, but their response depends on both their age as well as what they have been told about risk. One of the most important parts of engagement is risk perception. So we know, not just from type 1 diabetes, but in general in medicine, that what you tell a patient isn't necessarily going to be what they hear or what they understand or what they retain. So risk information is often not fully understood. More than 30% of mothers and more than 50% of fathers in the TEDdy study incorrectly reported that their child was not at increased risk of type 1 diabetes, despite the rationale for their recruitment being that their child was at increased risk for type 1 diabetes. So type 1 diabetes risk is particularly difficult for children to understand. And one of the aspects of long-term follow-up is that over time, some parents and children may become convinced that they will not progress to stage 3. And finally, an important aspect of assessment and education is that families will engage in behaviors in attempts to prevent T1D, despite being told either that these interventions don't help or that there's no evidence from them. And one of the biggest things we see is alteration of diet. So I just want to emphasize that accuracy of risk perception is associated with participation in monitoring. So goals of psychosocial support. In general, to assist individuals and their families to successfully manage the psychological impacts associated with this life-changing news. Goals of education have some overlap. We're teaching about safe monitoring practices, trying to encourage an appropriate risk perception, helping families understand specific outcomes. What are the stages of T1D? Where are you at in those stages? What are the symptoms of hyperglycemia? What is DK? Why does it happen? And why is there a need for insulin therapy when that does develop? We know that one of the important things about monitoring and education is to try to have a better status at onset of stage 3. So that's minimizing DK, but also reducing the need for emergency department visits or ICU stay. And then it is also really an important part of education is to help families understand options. So now that we're in a new era of having a FDA-approved intervention, families need to understand whether or not their loved one is eligible for that and what that would entail. And there also is an importance of pushing the field forward by encouraging families to understand what are the research trials available and what does participation mean for them. And finally, there's an opportunity to optimize psychosocial interventions to improve mental and physical health of the individuals and families, both healthy coping and healthy lifestyle. So I'm going to talk a little bit about psychosocial assessment during follow-up. There's an essential first step, which seems quite obvious, but I think families will tell us this is so important, that we don't just give them information, but then we take a moment and ask them how they feel about it. What are their reactions? After that first piece of information, it's important to integrate evaluation and assessment into monitoring visits. What are your current needs? How are you coping? How are you coping with the uncertainty, the anxiety, and then really concrete things like the tasks involved in monitoring. Many children have needle anxiety. Many adults also have anxiety around blood draws or finger pokes. There are areas for assessment, including assessing individual and family strengths and challenges. That can be anything from their emotional, cognitive, and behavioral function to any language and cultural issues that may present barriers. In pediatrics, it's really important to understand the developmental changes that impact your response to risk. So a preschooler is going to feel very differently about this information about risk than a teenager who is trying to adapt to their peers. And then finally, the family history of T1D, as mentioned. We should be assessing for symptoms of depression or anxiety, ideally using standardized and validated questionnaires, understanding the person's risk perception as an opportunity to assist with that, and then finally assessing for behavior changes. Overall goals of our messaging. One of our biggest jobs is to help families manage anxiety. The team's tone and language and how they talk about the information they're sharing with families can really give families cues about how serious is this information, how should they be reacting to it. And it's important to make sure you have resources in place to develop those long-term relationships that will help keep families engaged. Our sweet spot is healthy concern. So we don't want too much anxiety. We know that when families get very anxious, that can lead to unhealthy coping, denial, and discontinuation of follow-up. This is just too much. I can't do this anymore. But if families have too little concern, then there's no real reason to stay engaged with this process, and they might also discontinue. So we want alert to the risk, but not alarmed. Some communication strategies are clear and consistent messages. So the healthcare team and the written material that you provide should be consistent. We want to also avoid mixing numerical concepts. You don't want to throw lots of different numbers at people, 50% in 5 years, 70% in 10 years. What does this all mean? You want to be very consistent. And another approach is to pair scary information or anxiety-provoking information with some actionable steps to give people concrete things that they can do. So we're telling you we're uncertain when stage 3 will develop, but we can give you a clear plan for our follow-up and also for what we'll do with monitoring. We can give you resources and assure you there'll be considered continued support throughout your journey. We're going to describe symptoms of T1D, and then we're also going to give you a home glucose monitoring kit so you can check a blood sugar when you think maybe that symptom is there. Also, written and clear instructions about when to contact the team and who to contact. And another way to reduce some unknowns is to meet the care team, see the clinic, understand more about what's going to be happening in the future. So we talked a lot as a team about who should be delivering this education and psychosocial support. And as you can see from the previous presentations, there really is a spectrum of who is involved from the very beginning of screening all the way up to the time that someone progresses to stage 3. So depending on your area, your role and responsibility might differ, and also might differ based on health system with the configuration of who is doing what. But in any case, the education and psychosocial support should be occurring at some level at all levels of your interaction. We know from stage 3 that patients and families benefit from multidisciplinary care with a strong and coordinated team approach. So when and how do we provide education? So education ideally started before we're even in this situation of monitoring, before there was even a decision to screen for type 1 antibodies or genes. So, but once somebody has been told that they have early stage type 1, at that point, anytime the family needs it, and also at diagnosis of each stage, it's important to continue to educate, as people will forget or not have some of the information at the top of their head. So annual review of information, particularly when to test symptoms. And then also during life transitions and milestones when your care needs changed. So your child is going to high school, they're going to be spending more time independently, giving them some cues about what kind of things to be looking for. It's important to layer education and information as needed, so trying to link what you're educating to what is happening with specific time plans. The educational intensity should change by the age, family history, and preferences of the family. And with families who do have a history of type 1 diabetes, it's important not to assume too much pre-existing awareness, as there's a lot of variability into what they might have heard in the past. And then we encourage a variety of modes of education, from virtual, telehealth, videos, online, printed materials, etc. One little side note, I think it's important to recognize that early stage identification is a real opportunity to address some disparities in care. We know that decay at onset happens disproportionately in historically marginalized communities. But if we are screening equitably and then making a real effort to keep people engaged, then we have the opportunity to make a difference. So education really should be person-centered, accessible, engaging, and considering the needs of the family. So in summary, risk information can cause anxiety. Regular assessment is critical. Psychosocial support, education, and resources should be ongoing, and messaging should be consistent. It's very important to pair information with actionable steps, to have resources in place to build and support a long-term relationship. And finally, the accuracy of risk perception is associated with participation in monitoring, and so is an important goal of our education. So pairing early diagnosis with education and psychosocial support is an opportunity to improve the experience of diagnosis, promote healthy coping, and provide equitable access to care. And with that, I'm going to hand off to Dr. Sanjoy Dutta from Breakthrough T1D.
Good morning, everyone. So I'm here to close it out. I want to thank the chairs and ADA for giving us the opportunity to present this very important work that, as you saw in earlier slides, many people were involved in. So now that we have a roadmap to set best practices, standardize them as much as possible globally to monitor individuals in pre-stage 3 type 1 diabetes, in our humility, we know there are areas where we could not reach consensus. There are research gaps that need to be addressed, and there are clinical unmet needs that also need to be addressed. And I'll walk you through them very briefly. Don't have any relevant disclosures here. So unmet research needs, and I have 2 slides. So this is a subset here. We at Breakthrough T1D and many other funders are feverishly pursuing methodologies to close these knowledge gaps there. So we have a fully informed idea of how we can move forward. One here is the long-term progression in stage 3, two stage 3 diabetes in islet autoantibody positive individuals, particularly in adults, but also in all populations, and without a family history. And how does that progression differ in people of non-European ancestry? As you've seen, a lot of the data, we have learned a lot, but they're mostly from people originating from the Caucasus Mountains. And how does it progress? How does it manifest in individuals of other ancestries here? And then Dr. Schulbaum also presented about the pregnancy here. What is the impact of pregnancy in individuals, in women that are islet autoantibody positive? How does it progress? Is it different because of the challenges of pregnancy there? And what happens postpartum, after pregnancy? Likewise, following pregnancy is how about the neonatal outcomes? We know that neonatal outcomes are compromised in women that have diabetes, even if it's gestational diabetes. And we have been monitoring the NICU neonatal intensive care unit data there. How does it differ or intensify in people that are islet autoantibody positive and in their children there? And then a huge topic of priority for us here at Breakthrough T1D and many others is this incredible tool that has been transformative for people with diabetes, CGM, continuous glucose monitoring here. How can we leverage this technology, this revolutionary technology, to improve our prognostication and also about monitoring here? And then the cost effectiveness. These monitoring strategies will involve people, will involve resources, but at the end will obviously have a benefit that will outweigh the cost of it. But what is the cost of the monitoring strategy here? Another hot topic that was discussed a lot during this process of the 14 months that Anastasia showed here is the timing of insulin initiation in people that are pre-symptomatic, not yet clinically diagnosed with type 1 diabetes. And they could include short and long-term metabolic and mental health aspects of it. And then the impact of education, as Dr. Frohnhardt just talked to us about here. What is the impact of education alone, independent of other monitoring activities here? And how does it impact on at least the acute outcome of DKA? And then methods of identifying and monitoring behavioral health needs in individuals in early stage, which is also something Dr. Frohnhardt briefly touched upon. So those were the research gaps we're trying to close, or at least a subset of them. How about unmet clinical needs, identified by the working group over the last several months here? So comprehensive and consistent education materials that use consistent language and vocabulary, geospecific vocabulary here when referring to diabetes stages and risk, and how do you transfer that message? How do you communicate that there? A huge gap in the field in general in endocrinology, particularly in diabetology, and also in psychosocial and other educational care in diabetes is the dearth, the paucity of expertise in T1D. And how do we include this in early stage in youth and adults? And how do we train other individuals, HCPs, to be able to provide this, this support system here? And then how can we validate not only standardize but also validate these measures of anxiety, depression, and other mental health associated with type 1 diabetes, and also in people in islet autoantibody positive individuals here. And knowledge and coverage of appropriate monitoring of stakeholders, insurers, clinicians to begin with, and many, many other stakeholders here. It is going to literally take the village to be able to accomplish this. And then the timely access to the experts, to the HCPs and other experts here, and centers of expertise there. You need this level of expertise to be able to deliver this here. So we talked a lot about monitoring because it is an urgent clinical need. It's an urgent gap there. And as one of my co-panelists mentioned here, screening alone doesn't prevent DKA. It's the monitoring that prevents DKA. So it was an urgent need and we addressed that. What about screening guidance? So we have incredible tools right now in islet autoantibody detection, but there are other methodologies and technologies with advancement of both knowledge about the pathogenesis, etiology of type 1 diabetes through decades of research, but also understanding the diversity in this incidence of the disease here. So we should try and do so. Any ideas you have, suggestions you have, please do reach out about screening guidance, and we will try to get this also in place here as soon as possible here. So I will end my talk here and end at the very beginning that Dr. Albanese O'Neill, my colleague, mentioned. I want to thank everyone for your attention and also the many, many people that worked on this and have dedicated their lives over the last several decades to help people at risk as well as with frank type 1 diabetes. Thank you all.
Thank you to all the speakers for sticking to time. Fantastic. For one job well done for bringing together such an amount of work in these few minutes. The floor is now open for discussion, and we welcome any questions. This is a consensus, and so all of us had to yield on some discussions. I lost, for instance, the discussion on the dichotomy between pediatrics and adults. You know, I don't believe that when you're 18 plus 1 day, you become a different person. But anyway, this being said, the floor is open. Sufyan.
Thank you very much. Sufyan Hussain, King's College London. Firstly, congratulations to all of you on putting together this very, very timely piece. Really grateful to hear the emphasis on psychosocial support, education, as well from Sanjoy about the disparities, because clearly there's unmet needs there that need to be overcome with what we see in our very highly ethnic population in London. The bit I wanted to focus on or ask was, there wasn't really much mention of peer support. And I just wanted to get some thoughts from yourself, because this is an area that I practically see very important in clinic when I come across people, you know, who are in stage 3 or even early other stages and stage 2, and try to connect them with people to understand, you know, or speak to others, because obviously they can hear it from our language and tone, but they need to hear from peer support as well, from peer groups as well. Was this mentioned, or is this something that's buried away? And I'd be really grateful to hear your comments. Thank you.
Brigitte, will you take it?
I didn't quite.
The peer support.
Oh, peer support. Oh, yeah, that's a really great question. I mean, we know in stage 3 that families very much benefit from peer support and from feeling included in a larger group and not the only one. And if you think about right now, the relative infrequency of screening for early stage type 1, that's an even more solitary island that somebody could feel like they're on. I do think for instance, the TEDdy study, that we did see families appreciate connection to other people in the study. And that's definitely something, as we're designing plans going forward, we are thinking about ways to give people community. So we have a program that we're going to be recruiting for this summer at Sanford and other places, and the Barbara Davis Center. And one of the elements is a group session with education. So there's an opportunity to have a little bit of interaction. But it is a question, and I think using social media and things like that can be a little tricky. So I do think it's something to explore, an important point.
Yeah, and again, from other projects throughout the world, we do know that peers can be essential also in helping all these setting up all these educational materials. And our spider in the web, Dr. Albanese O'Neill, of course, is already working on it. Anastasia.
Yeah, thank you for bringing that up. You know, we at Breakthrough T1D have families coming to walks who have children who are autoantibody positive but have not progressed to stage 3 type 1 diabetes and are saying, well, where do I fit in here? They're asking about CAMP. They may be wearing CGM because that's how they're being monitored. I feel very grateful. We take a lot of those calls. My team is here. We take a lot of those calls one-on-one. We also have individuals who have undertaken teplizumab, MZWV therapy, and now are saying, well, what's next? And require monitoring. I'm happy to say we have money in the budget in fiscal year 25 that starts the 1st of July, and we'll be working on these programs and would love your partnership as we build them, not just here in the United States, but globally, because this is a new population of individuals who need peer support and need partnership and other families and individuals to talk to. Thank you for the question, and we are with you in moving forward.
Please go ahead.
Hi, I'm Christine March from Children's Hospital of Pittsburgh. Thank you so much for all of your hard work and your wonderful presentations. I really look forward to reading the document. I also have a question about the psychosocial support. As a pediatrician, you know, even though my patient is the child, that's really the whole family. And I think paying attention to the psychosocial needs of the parent is also very important, and you did touch on that. But I'm wondering, you know, with definitely a taxed mental health care system right now, you know, and I may have access to a diabetes psychologist, but they're for children. How do you recommend we connect families to care for this? And would there be a thought of maybe family-based therapy?
What was the last thing? I'm sorry, what was the last? Would there be a thought of?
Family-based therapy.
Oh, family-based therapy. Yeah, I mean, I think our appreciation for the importance and our resources to do anything about it are quite disparate, and not just in T1D. And so I think, you know, a lot of our efforts with psychosocial support is really identifying people who are at the highest need and trying to direct them to resources. I do think there are situations, I mean, one of the points I made is there's an opportunity to address situations. So say you have, you know, multiple households in a contentious situation. If you could get that somewhat improved before you have insulin and all the other pieces, that would be great. So yeah, I think there's a role for family therapy in a lot of situations. And I also think going back to peer support, sometimes when we don't have great resources for mental health, at least building community is a good place. But yeah, I know I think they're really important, and I think one of the goals of our community should be trying to encourage more mental health providers to have expertise in relevant areas.
Excellent. And Dr. O'Neill just said, I can comment on funding and initiatives in Breakthrough. So money is there for research in that area.
We need more expertise in this space, and we welcome your proposals so that we can provide the appropriate psychological care. And I see Dr. Suzanne Johnson in the audience, who is an expert in this space. She may want to comment, or you can visit with her afterwards, please.
Excellent. Question, please.
Hi, Charlotte Singh, Sanofi. Again, just want to congratulate you on your consistent and concerted effort over these past 2 years. Really well done. My question is for Dr. Rivka Shulman-Rosenbaum. When you were describing single antibodies in adults, I happened to notice that I don't think was listed was adults with having other antibodies for other autoimmune diseases or having a history, either personal or family history of autoimmune diseases. I just wanted to know why that wasn't included as a risk.
So these guidelines, again, are not meant to say who should be screened. We did not cover that aspect. Yes, there would also be a risk of having other autoimmune diseases. It just wasn't something that was specifically put into the guidelines, but good point. Thank you for mentioning.
Can I just take the prerogative here of asking Linda and Kurt? I mean, single autoantibodies is probably the most debated topic in this whole thing. Can you comment on, the type, a GAD just above the threshold, or having IA2, both in adults, children? Do you want to take it, Kurt?
So I think, and unfortunately, the answer is it depends. And for me, again, coming as a pediatrician, the age of the child, the age of the adult really changes that context. And if you think about, a 12-month-old who's just developing anti-insulin antibodies, that one antibody that early, even at a low level, is very concerning, and they're at high risk of progression very quickly. If you have an adult with, my body habitus, a little GAD antibody, who knows what that means? It's probably very different situation there. In addition to age, which antibody? I know not all the pharma companies are enthralled with the idea of splitting the market up into endotypes and making each one smaller, but I think there is some heterogeneity besides just age. And if we think about maybe the early kids start getting insulin, maybe the older kids, if they start later, they start maybe with GAD and different HLA associations there. One of the things that's coming out of TrialNet is if you find somebody that has a single autoantibody as IA2 or ICA512, that's actually probably concerning because that's one of those that comes later as epitope spread, we think. And you may have lost the insulin antibody that you had. And as we look at data from TEDdy, these wonderful longitudinal studies from DIP, we can see the evolution of that. As we're looking ahead to where we're just screening and we catch a teenager, we don't know what they had when they were 2 or 5. We see where they are now, and that's IA2. And having IA2 by itself really puts you at the same risk as having multiple antibodies, probably close to 50% progression in 2 years. Linda, do you want to add something?
I'll just add that there's an excellent review by Jamie Felton as first author from the Precision Medicine Initiative that goes through the various antibodies and the likelihood of progression based upon them. I'll say that those data, going back to Sanjoy's comments at the end, are limited because most of the research has been done in white pediatric populations, so we also need to learn more about what these antibodies mean, particularly single antibodies in other populations as well, because I think there are some emerging data. And then based upon some work that we had done that I presented earlier at this meeting, time of day, particularly for low-level antibodies, may make a difference as far as what's considered positive. So think just an extra thing to think about as we're assaying these things.
And again, Dr. Albanese O'Neill says there may be money out there for more research. I'm going to need quick questions, quick answers. You were first.
Yumi, I'm from University of Iowa. I also would like to congratulate the wonderful guidance we have. I'm an adult endocrinologist, and with the FDA approval medication, I do see type 1 patient. And is this something I should now promote, that the screening for the family members of the type 1?
Yes.
Oh,
Peter.
That particular recommendation is in the ADA standards of care.
Yeah, so we didn't say anything about screening. Again, the spider in the web already started an initiative. We sat together 2 days ago, so there will be a new clinical guidance also on how to screen. But I think in family members, it's time. Anyway, Peter.
Peter Senior, Edmonton. Just a question about the 10% change in A1C. Given the lab imprecision of A1C estimates, is that a concern, or in adults should we just sort of say, let's stick with 6.5 because you've got diabetes now and you're unlikely to have DKA perhaps in adults without getting beyond that threshold?
I'll let the working group leads answer the question that you posed, but I will say that is something where we did come to consensus, although we had a lot of debate. So there are a couple things in the guidance that we say we never came to consensus. There we came to consensus, and I'll let them talk about precision of labs, but as a whole, we did that as like the process person here, we did settle on that. But go ahead.
All right, so again, we have some guidance here. Yes, every lab is going to have imprecision as you measure it in one place versus another. Hopefully all these things are getting a little more standardized over time. We're not going to say necessarily this is something that is a clean definition that you act on right now. It's a sign we need to look at this again. This is if I see something like that, I'm going to want to see, in my world, an OGTT on the kid and see, let's answer this cleanly, but that's a warning sign that at least catches our attention early.
Thank you, and we're going to need to wrap up here. I'm giving the last word to Dr. Albanese O'Neill.
My last word is just a thank you to Dr. Phillip for chairing the workshop, for Dr. DiMeglio for serving as vice chair, and for everyone on the panel, in the audience, and out there listening who put in countless hours that were unfunded to put this guidance together. It was beautiful to see the type 1 diabetes community come together and create this document that's now online, and we look forward to partnering with you as we move forward. Thanks for being here today, and thanks for the group.